The first question we received is a very interesting point about the use of molecular profiling. So the question is there any situation outside a clinical trial where you would recommend ordering a molecular profile, like a gene panel screen, for management of metastatic renal cell carcinoma? And would you, for instance, use that kind of approach in non-clear cell histology?
Yeah, I think this is very important, and this is a question that is not applicable only to renal cell cancer, but also to multiple other solid tumors, especially when there is no standard, such as non-clear cell renal cell cancer, and there are several companies and several platforms that look at this. I think if you look at clear cell RCC, for example, and look what are the mutations, most of the mutation beside VHL are chromatin modifier, and the drugs are coming, but they're not yet there. I would imagine that perhaps if there are some mutation in genes where you can have an analogy from other tumors such as lung cancer and EGFR mutation, knowing that this could be a totally different mutation than the one in lung cancer, then sending the patient to early drug development and clinical trial is reasonable when they progress and when their standard therapy failed them. But I think it's important to discuss with the patient so that they understand that even with the molecular profiling, we may not have answer. And in fact, most of the time, we don't have answers. We have some genes, and we cannot pick out the right drug. But I am quite confident that the future, the next 5 and 10 years, will lead to a better understanding what these mutations are, and drugs will be a drug, not just approval, but the drugs in general and the pipelines will be accelerated to focus on that. Not yet standard, but hopefully in the next 5 to 10 years, these are very exciting times for genomics.
It is. Thank you for that answer. The second question we had was regarding a point that might have been discussed this morning as well by Dr. Hirschman, that was discussed. It's on the role and the importance of the surgery of the primary tumor, meaning the kidney. Mm-hmm. So do you consider that with the new developed agent, and especially the new potential immune therapy that are available or that will be available in the future, if approved, shall we once again raise the question of, do we have to remove the primary or not?
I don't know. I don't know, to be honest with you. I think this is a very important question, and you know, removing the primary, we know it's of benefit in the cytokine area where we had interferon, and at least in the VEGF target therapy from large studies we've been involved with, you know, removing the primary will lead to a survival benefit. But I think that the question here, the main question here is not yes or no, is picking the right patient. So a patient with good performance status, without a lot of metastatic disease burden, who's a surgical candidate, who has a good kidney function. You don't want to start with someone with diabetes with a GFR of 25% and 25 cc a minute, and then get them to dialysis. I think here a multidisciplinary approach between urologist and medical oncologist is important. I think for the average patient in this stage, an average patient that meet all those criteria, considering taking the kidney out is very reasonable.
Okay, thank you. Talking again about systemic therapy, the question is, do you believe that the new immunotherapy you have mentioned, and especially the PD-1, PD-L1 axis blockade, has the potential to achieve complete and sustained remission in patients with metastatic disease? And do you believe that the tumor burden in itself, meaning the importance of the metastatic spread, is an important factor for the immune system to be able to control the disease?
Yeah, I mean, I think this is, again, a very interesting question from a knowledgeable you know, audience here that, that really is important in this situation. I think if you look at the phase 2 data from Dr. Mozers and others, the rate of CR, complete responses, were very, very, very low, if any. So this is very important to consider. I think there is a subset of patients who benefit. We don't know who is those patients. We looked at patients with PD-L1 negative can still respond. The future could be combination therapy here, but I would be careful into making a statement that these drugs, you know, immediately gonna go to complete responses. In fact, if you look at single agent responses, is between 9 and 20%. Certainly there is some activity, but most of these responses are partial responses. And my other question here, this is immunotherapy. Would you continue the drug? Will you stop after a certain time? All what we have is how these drugs are used now. We don't know. There are some patients that may benefit after 3 to 4 doses, and there are other patients where you need them to probably continue. We know with tyrosine kinase inhibitor work from you, Dr. Albuquerque, Dr. Escudier, and others, suggests that I would say the majority of patients, when you stop treatment, the tumor may grow. Not everyone. So we have that question, we'd have that answer that came several years after the approval of these drugs. I think we need to stay tuned, but overall, to summarize, the rate of CR, complete responses, are very, very, very low, if any, with single agent, at least from what I presented with nivolumab.
So this leads to the next question, which is, in fact, regarding the benefit that is currently being seen in melanoma patients with that kind of approach. Do you feel, in the experience you had across your clinical trial, that there is the same range of benefit for renal cell carcinoma as what we see in melanoma?
It's hard to say. These are totally different tumors. I mean, we all start for obvious reason with tumors that are well known to be immunogenic, renal cell carcinoma, and a melanoma, but a tumor that, at least to my knowledge, is not immunogenic, where interleukin-2 and interferon alpha were inactive, like non-small cell lung cancer. Suddenly we see responses in PD-1 inhibitors. So I think the whole field here is evolving, and we're redefining what we know and don't know about immune checkpoint blockers. And this is very exciting. And hopefully it will live, you know, to the hype, and we will know if that happens from mostly randomized phase 3 trials. Again, as long as we don't see durable, complete responses happening, and we're not seeing that with single agent, at least in renal cell cancer.
Okay, so switching back now to the approved agent, the question is, do you consider that all patients should be offered at least one VEGF inhibition line and at least one mTOR before being referred to clinical trial?
I don't think so. I don't think so. I think we should always build on the current status. If there is availability for clinical trial, both drugs, both class of agent are not curative. I think even with first-line trial, when it's reasonable to offer a trial, even when you have agents such as sunitinib and pazopanib, and if this is available, it's very reasonable. At the end of the day, it's a discussion that happens in the room with the patient, a discussion about the pros and cons about clinical trial, about standard therapy and other, and it's taken in consideration the comorbidities of the patient. Let's not forget that patients included in clinical trial are not 100% the patient we see in practice. Looking at the International Metastatic Database Consortium, that is a consortium of 20+ institutions across the world in RCC. If you go back and look at those 3,000 patients and compare them to eligibility, look at their baseline characteristic and look at the eligibility criteria, if you're going to enter a first-line trial, 30 to 40% will never be able to enter a trial. We don't have data with these patients. So a clinical trial still is not for everyone, but when there is opportunity, I think it's important to advance the field, and it's important to show the patient that we can do a better job and we can get a better outcome.
Yeah, sure. And I think we can emphasize the importance of the overall strategy, because all patients won't be able to receive second or third line because of progressive disease, and it's highly important to be able, within one patient, to have a front line that is efficient as much as possible, and then define the subsequent line in regard of the kind of the disease in the patient.
Absolutely. I think after VEGF and mTOR inhibitor, there are patients, for whatever reason, a decline in performance status, and others are not able to receive other treatment. I think the idea here that we should leave the patient till they progress on whatever standard, I personally don't agree with it. I think clinical trials can be at any stage, used if they make sense, and hopefully they lead to better outcome, and they have an appropriate, at least, control arm.
Okay, thank you, Tony. We'll take one more question, which is, do you feel that more potent VEGF TKIs are needed in clinic, or should we drive our efforts to develop that kind of new drugs with other targets?
Yeah, I mean, this is a good question. I presented the data with tivozanib and axitinib, and I think this is a lesson for all of us in trial design, and both drugs, because probably of trial design and whether with axitinib underpowered, led to negative results, at least to results that did not lead to the approval of these drugs. And how many times we can repeat and repeat and repeat with a new target. I think at this time we have reasonable VEGF tyrosine kinase inhibitor. I wouldn't be completely close to trying a new TKI in an appropriate a patient that provide perhaps more efficacy and better tolerability profile for sure, but at least with the opportunities that were handed to us at this time, both potent TKIs, axitinib and selective axitinib and tivozanib, the trial did not lead to results that will lead to using these drugs in the first line.
Absolutely, and it's exciting to see this field evolving with the new agent as well. Absolutely,
with agent that gets you one step ahead, VEGF resistant, when you target MET, for example, or others, the FGFR or others, despite the initial negative experience, or now novel immunotherapies and potentially vaccine. At the end of the day, we want to try as much as possible to bring a novel agent to the patient, novel agent that extend this life. Median overall survival, before the target therapy era in renal cell cancer was 10 to 12 months, and now it's exceeding 30 months with opportunity. We cannot stop here. Yeah, we have to continue.
Absolutely, and this happened in a time frame of less than 10 years.
Absolutely, absolutely.
So this is really important for the patient care. One last word on combination, Dr. Choueiri?
I think that a combination of target therapy has to be taken with caution. The experience has not been favorable so far, but with novel PD-1 inhibitor, the experience is being repeated. I hope these are going to be tolerated, but I think based on what was presented at ASCO, we need to proceed, but we need to proceed with caution, no doubt.
Okay, and one word on non-clear cell?
Non-clear cell is an open box. Non-clear cell is more than 7, 8, 9 types, and at this point we know that target therapy do have some activity, probably less than a clear cell, and we don't know the strategy to start with. A study presented at ASCO by Dr. Tanier showed everolimus not to be superior to sunitinib in non-clear cell histology. I think hopefully that new drugs, and hopefully with the TCGA data coming up, will come up with a new target. MET, for example, seems to be an interesting target in papillary RCC, and there was some ongoing studies. But I think this is a situation where genomic profiling may be interesting and patient can go through treatment. The problem I have with non-clear cell is that a lot of trials we have do not include non-clear cell. I mean, for reasonable for reasons that are related, in fact, to the fact that the biology is different, so we don't know what we're dealing with. This may make the trial a bit heterogeneous. But I do think personally, taking care of a lot of patients with non-clear cell histology, that at the level of the phase 1 study of the non-registrational studies, it's very important to have non-clear cell histology and to take a look at this. In the registrational studies could be different, but at least in the early studies, it's very important to cast a wide net a bit so that these rare diseases and patients with with these rare diseases have options for these novel agents.
Would you recommend these patients to be referred to specific institution for clinical trial?
Absolutely. If these trials are available at larger institution, it's very reasonable to come for an opinion, you know, and see what we can offer and what we have and what's the menu du jour in terms of clinical trial.